it's so nice that you're inclusive. So, all right. So this lecture today is on lengthening of the upper extremity. And we will, at the end, as she said, I will give the option of doing some slides also on the lower extremities because there's apparently a lot of interest. The upper extremity lengthening is, oh, why is that not moving? Hold on. There we go. Is the easiest of all lengthenings. And typically it is folks that are having the humeral lengthening with different types of dwarfism, but especially with achondroplasia, because we know that there is a shorter extremities than the spine, and the indications are basically two basic scenarios: bilateral humeral lengthening in dwarfism, achondroplasia, hypochondroplasia, and pseudoachondroplasia. And then also there's the option of unilateral lengthening for folks with other types of issues where they have a discrepancy between the right and the left. This sometimes occurs with neonatal sepsis, obstetric brachial plexus injury, osteosarcoma, multiple hereditary exostosis, and Olier's disease. These are some of the patients and the diagnoses that we have done unilateral lengthenings with, and they're very successful. The treatment options: for a simple lengthening, you can use an external fixator with a monolateral rail. It was, we used to use the modular rail system, but now we have a newer system called the drive rail. And then there's also an internal option, the precise intramedullary nail. We have a patient actually who will be coming in later today who has had both. And he is just 1 week into his lengthening with the precise intramedullary nail. He's also had lower extremity lengthenings too. So when he finishes his therapy session today, he's going to come in and kind of hang out. So if you have questions, he would be a really good person to pose those questions to. Also, if there is an angular deformity with length or rotation correction needed, there is another option. Come in. I think he's here now. Come in. He'll figure it out. So you can use a Taylor spatial frame or a Vilex frame. In the past, we used the Taylor spatial frame, but we're now using the Vilex frame. They're computer-driven frames that can correct deformity on multiple planes at the same time, and also for length. So those are really nice tools to have in your toolbox. This is a humeral lengthening on a young man who had a unilateral limb length in his upper extremity with deformity. His diagnosis was Olier's disease. And so you can see that he has the, I believe he had the Taylor spatial frame, because this is a few years old now. And here's his pre-op. Can you see my arrow, guys? Yes? Okay. So you can see here's his pre, and he had quite a discrepancy, and then his post, and he ended up being even and straight and no angular deformity. And this is an example of a lengthening with this young man had a modular rail system. Now, again, we would use a similar system, but much better is the Vilex system. So he has the external fixator. So this is just x-rays of folks with the Taylor spatial frame on different parts of their arm. So this is a humeral correction and lengthening, and this down here is a radial ulnar. So they can be used on basically any parts. So the rationale for humeral lengthening in achondroplasia, we talked about that achondroplasia is the most common indication for bilateral humeral lengthening. And we talked about also the disproportionality of limbs to trunk, so the rhizomelic disproportion. The trunk is of roughly normal length, but then the limbs, especially the upper limb, is much shorter in comparison. So upper limb lengthening increases the function and the independence with basic living skills. I want to take a moment to discuss how the spine is, it can be very, very debilitating as one ages or as spinal stenosis sets in, especially in folks with achondroplasia, because we know that if your arms are short and your trunk then is stiff, it becomes very, very hard to take care of personal needs such as toileting and your personal hygiene with toileting. When a child is young and their spine is flexible, it's not as big of an issue, and they can usually learn to toilet very well and clean themselves and whatnot. But we've seen a number of cases where kids develop spinal stenosis young and either end up needing fusions because they're losing motor function and their spine is not stable enough without the fusion. And then they lose the ability to dress themselves and care for themselves. Oh, I just realized my door is locked. 1 second. And I'm so sorry. Sorry. Our patient that was going to come in was standing outside. I forgot I locked my door. So anyhow, so once a patient has undergone a fusion, if their arms remain short, it is extremely difficult to take care of themselves while toileting and while getting dressed. So that is a really big indication. We've had some young children that have had to undergo that surgery and then end up, even though they decided not to lengthen for height in the lower legs, or in the legs rather, they've chosen to do the upper extremity lengthening for function. So I just wanted to take a moment to address that. Okay, so forearm lengthening with an external fixator, that also occurs sometimes in other types of dwarfism or dysplasias, or also with somebody with achondroplasia who has some deformity in the lower arm as well. So here's some examples of the fixators used for that. You'll also see a hand splint there, because if you're lengthening the lower arm in particular, you really need to support the fingers so that they don't get tight as the bones lengthen, similar to how we support the foot when they're undergoing a tibial lengthening. So the Paley method of four-segment or extreme lengthening is around 8 to 10 years old. They'll do both tibias and femurs, and they will gain 4 inches in total. And then around 13 years old, they'll do again, so every 4 years-ish, they'll again do both tibias and femurs, and gain 5 to 7 centimeters in the tibias and 6 to 8 centimeters in the femurs. So they'll get about 6 inches with that one. And then between 14 and 15 years old, or within another 4 years, they will undergo the humeral lengthening. Actually, I'm sorry, usually we space that somewhere in between 2 leg lengthenings. Sometimes they'll do it between the first and second leg lengthening, and sometimes they'll do it between the second and third lower extremity lengthening. So really that one can be thrown in somewhere in the middle there. And the patient can get up to 10 centimeters with the upper extremity lengthening of the humeri. And then for those who want it, they can undergo around 16 years old, another lower extremity lengthening, which is a 4-segment lengthening. So there's, again, it's really driven by the patient and what they want and what their needs are. We've had patients that have come and they've had 2 lower extremity lengthenings and they're perfectly happy with their length and they're perfectly happy with their function, and they stop at that. And then we've had some that have come for 3. And the upper extremity lengthening is usually done in 1 lengthening. Okay, So during the upper extremity lengthening, it can be treated by either an occupational therapist or a physical therapist. Either discipline treats that very well and does a great job with it. Typically in our center, they spend a couple days max at the hospital. Sometimes they're only there for overnight. And then they come to see us 24 to 48 hours after they're discharged from the hospital. So we get them right into therapy right away. During the initial evaluation, whether it's with an occupational therapist or a physical therapist, it needs to be based on what the doctor has prescribed, so, and the surgery performed and risk factors. So it's a little bit different versus if they've had an internal lengthening or an external, or they have a talar spatial frame or a Vilex, slightly different, but the tenets are pretty much the same. And on that first visit, you do not have to be really aggressive. You want to build some rapport with the patient, and you want to build confidence so that they know what they're going to be doing once they go home. You want to start with range of motion and teaching them how to care for their fixator and how to position so that they don't get tight. You want to assess their pain, sensation, posture, skin and pen sites, range of motion, strength, balance and coordination, and their ability to perform ADLs and dressing. Sometimes they may need some special adaptations for their clothes, and that's sometimes something that not only the therapist discusses, but our families have a network, and our patient care coordinators help with that. So those that are lengthening the lower arm, the radius and the ulna, will usually need splints, as we discussed for the hands. Those undergoing humeral lengthening usually do not need splinting, especially not at the beginning. Towards the end, if they get really tight, we may fabricate a splint to help them maintain extension, but really that's quite uncommon. We don't usually need that. And then you also want to establish a home exercise program, because they're only in therapy 1 hour a day max. Sometimes with the upper extremity lengthening, they can even get away with 3 times a week, as long as they're really compliant with their home program. But they need to be performing their home program 3 times a day. Okay, so this is the internal precise nail. And this is just an example of what that looks like. And this is at the beginning of a lengthening. And you can see the osteotomy right here. They usually distract a little bit in the OR just to make sure everything's working well. Okay, and then you can see with the external fixator, the modular rail or the Vilex, you can see this one is one that has distracted quite a bit. So let's talk about the lengthening protocol. With the upper extremity humeral lengthening, it's typically 0.75 millimeters of distraction per day. Typically, we also don't begin that distraction until 1 week post-op. The distraction goes on for about 4 months. Please be aware that if the patient begins to get tight and lose range of motion, they may slow that down. So it may go down to 0.5 millimeters per day. The goal of most upper extremity humeral lengthenings for folks with achondroplasia is 10 centimeters. And that is if everything's going well, they're making good regenerate, and their range of motion is tolerating that. So 10 centimeters is about 4 inches. Therapy is recommended 3 to 5 times a week. It is the only lengthening that we will allow folks to go home to their hometown and not stay locally for. We do have many that choose to stay locally for that, but it's more costly if you stay locally, and some people are able to stay here for a couple weeks, get everything organized and learn how to do the home program, and then they fly back home and continue with therapy home, and then they fly back in every few weeks for x-rays. And typically when they're here, for an x-ray and follow-up visit with the doctors, we also recommend that they have one visit with therapy here just to make sure everything's going well. We do not allow that with lower extremity lengthenings because just too much can go wrong. But like I said, the upper extremity lengthening is much easier, if you will, than the lower extremity lengthenings. Okay, if you have an external fixator, you can begin aquatic exercise as soon as 10 to 14 days post-op, as long as the active bleeding has stopped from the pin sites. And with an internal nail, you can do it around the same as long as your incisions have well healed. Patients will be monitored for splints as tolerated and deemed appropriate, and we talked about that. With the external fixators, they can weight bear as tolerated. We don't want anybody doing handstands, but if they need to lean forward and place some weight on their arms, that's fine. With the precise nails, again, it's a 50-pound weight bearing. Again, no handstands, even if you weigh less than 50 pounds, but you can lean on your arms if you need to. If you need to use an assistive device or something like that, you can certainly do it. By the 4th month, there's an increased risk of fracture just because you have elongated and there is more of a gap in the bone. You're still supported, but we usually decrease that a little bit. People usually don't feel like weight bearing too much through their arms at that point in time. And we don't want you doing any heavy athletics at that point in time. Okay, so the goals of therapy are to maximize the passive and active range of motion, to prevent contractures. Soft tissue length must increase as the bone elongates. So essentially, as your bone grows, your soft tissues are functionally shorter. They're not really shorter, but because your bone is longer, the articulations or the joints are what will lose range of motion. So we want to make sure that we're maintaining functional range of motion and as close to normal range of motion as possible of the shoulder, the elbow, the wrist, and the hand. Also, you'll see sometimes just postural forward position, because especially with the external fixators, because they're heavy and they wear you down. And let's face it, we live in a forward flexed society as it is. We work on a lot of screens. We spend a lot of time seated. So we want to eliminate or at least to minimize that as much as possible in the population that is lengthening. We want to make sure that they're able to do their activities of daily living, and that they're able to, dress and eat and go through life with as minimal issues. You want to make sure that the patient and the family, as I've already said, are independent with their home exercises. That is absolutely critical, because whether they're staying local with us or whether they're going back home, they need to be on board with that and comfortable with that. So what type of modalities do we use with this population? We find that moist heat after the first week post-op is very, very helpful. It increases blood flow and makes it much more comfortable to do the stretches. Manual therapy, meaning manual stretches, soft tissue preparation. We use a system called ASDD, which is a soft tissue tool. Other places use other types of soft tissue tools, and I think that they can be very, very helpful. But if you don't use soft tissue tools, you've always got your hands, and massage and soft tissue mobilization is very helpful. We also use kinesiotaping to address pain, and also to help facilitate proper alignment of the cervical spine and the shoulders, because again, we talked about the forward posture. So as we need to, we help them with kinesiotaping, just a kind of reminder. We do joint mobilizations as needed to help with that alignment and that motion. scapulothoracic, glenohumeral, humeral radial, as we see fit. You don't have to do that if it's not indicated, but those are things you need to be aware of. If the joint's not moving properly, you need to free it up. So muscles that tend to get tight, obviously the muscles on the segment that you're lengthening gets tight, but we've talked about the forward flex posture and how the fixator pulls you forward. So the pec minor and major, subscapularis, latissimus dorsi, the biceps brachialis, triceps also can get very tight. And depending on what muscle you're lengthening, you just kind of have to think about what segment, and you can see as a therapist working with a patient, what's restricted and address it. It's not a recipe where you go in, you do ABCD. You need to look at the patient. You need to see what's moving, what's not moving, what they're having issue with. And you need to be willing to think outside of the box. Do they need a splint? Even though that's not a typical indication for a humeral lengthening, it can be very helpful if it's needed. So in these photos, you can see some of the stretches that we have them doing. You see in the picture on the left, I'm holding his scapula into position so that we're actually stretching the glenohumeral joint, because if I don't hold my hand there, his scapula tends to wing out and you're not actually getting the joint that you are intending to stretch. And over here, you see he's at a more advanced stage and he is able to stabilize his scapula very well. Both of these guys have external fixators on. It's important when you're stretching any patient that's lengthening, whether it's an upper extremity lengthening or a lower extremity lengthening, it's important that you use short lever arms. So you want your hands as close to the joint as you can get them so that the force is not going through the bone, but you're really getting the soft tissue, and you want to minimize the amount of force that you're putting through the bone. So you can see in this, we've got our hands right there at the joint. So in another population, you might bring your hand down to their wrist, and that's a much longer lever arm. We really discourage that when you're dealing with a lengthening patient. As the lengthening goes on, the soft tissues become tight. So the soft tissues become a bit hard, and the bone becomes a little bit osteopenic. And so movement will take the path of least resistance. You want to make sure that you're affecting soft tissue and you're not going to create a fracture through the bone. So that's why we're using those short lever arms. That's also why we do the soft tissue preparation before we do that. So we're warming up the tissue either passively with heat or actively with exercise and soft tissue. And then is when you do your more intense stretches. So you can see we're using short lever arms close to the joint with each and every stretch here. These are some of the exercises that the patient can do for their home program. We often use dowels, or it can be a cane, whatever they have, to help them mobilize their own shoulder and their own joints. There are some TheraBand exercises that we can use also to help their postural exercise, or their postural muscles, to maintain the strength and support them through the lengthening. These are just some examples. You can also work in prone so that you're keeping the posterior muscles nice and strong. And again, so that they can support the fixators and maintain their body through the lengthening with good posture. You'll see this guy has a weight here. I'm not a real fan of doing weights with external fixators on. I'd much rather do higher repetitions, and because I think they already have a weight on their arm, but somehow a weight made it into my picture. Just wanted to make a note of that. Let's talk about some of the complications that can occur with humeral lengthening. As with any lengthening with a external fixator, pen site infections is something that can occur and often does. Typically, they're very minor and can be treated with some oral antibiotics. Sometimes you don't even need to go to antibiotics. You can just increase the hygiene and the washing to a couple times a day. But with pen site infections, they are often, the first sign is increased pain around a pen. You may not even see any discharge, but if you've got increased pain that you didn't have a few days ago, pay attention to that site and look for other signs such as tenderness, redness, cloudy drainage. Obviously, yellow or green drainage is a huge red flag. And if you do have an infection or those signs, multiple signs, you need to let your doctor know. Nerve complications can also occur. So that's why gradual distraction is important, and also why frequent follow-up is important. Predisposing factors can be a really tight fibroosseous tunnel for the radial nerve because it goes around the humerus. Premature consolidation is also an issue, or failure to consolidate. So if they're not having or making good regenerate with the 0.75 millimeters a day, they may slow that down for just the patient's not making enough bone and they want to slow down the distraction. Obviously, joint contracture is also a complication of any, or can be a complication of any limb lengthening. Again, of the humeral lengthening, that is not as big an issue as it is for lower extremity lengthenings, but it does occur, and that can be another reason that the lengthening needs to be slowed down or stopped. But again, this is the easiest of all. So after the distraction phase is over, meaning the active lengthening, you go into the consolidation phase. And that means when you've stopped lengthening and now you're waiting for the bone to fill in so that it's safe to remove the fixator if you had an external fixator, or go back to full activity if you've had an internal fixator. So for an adult, or rather, let's talk about a child first. If you have a child, the ratio is about 1-to-1. So if there was a 4-month distraction phase, the consolidation phase is going to be about 4 months also. Rule of thumb, but the X-ray is what's determining it, not the calendar. And if it's an adult, adults take a little bit longer to consolidate. So it's usually about a 1.5 ratio. So if you had a 4-month distraction phase for an adult, it's typically going to be about 6 months for consolidation. Therapy during the consolidation phase can typically fade. And it's based on right at the end of lengthening. If you're extremely tight, you may still need to be seeing a therapist 5 days a week if that's what you were doing at the end of your distraction. And then as your range of motion returns, you can fade that down to 2 or 3 times a week, or rather 3, 2, 1. And then you may hit the point where you're just doing maintenance at home. The goals of therapy during the consolidation phase are to reclaim the full range of motion, eliminate muscle restriction that's left over from lengthening, progress the strength, and progress weight bearing as your doctor indicates. Again, we don't go by the calendar, we go by the X-ray. And then the patient and family should be updated and independent with their home exercise program. So it's about this is a series of X-rays over a 6-month. Ooh, where's my arrow? I lost my arrow. Anyhow, this is, over a 6-month time frame, and you can see the left and the right and pre and post, quite a bit of length. So after the fixator is removed, if they had external fixation, the patient will be non-weight bearing on the upper extremity for about a month. They'll often get a clamshell brace to protect the humerus, and sometimes they'll be rodded instead, or sometimes they'll have a rod and a clamshell brace because the regenerate is more fragile, and certainly where the pin sites were removed is a place that can fracture. So you have to be careful afterwards for a little bit. Those that have the internal nail do not have that same issue. And once their nails are removed, that's usually about a year later. The patient may continue active range of motion, but passive stretches, if they had an external fixator, should proceed with caution. And if the physician, if the surgeon is very worried about that, they may just say active range of motion for the first 4 weeks. Once therapy resumes in full, you can do gradual progressive passive range of motion, manual stretches, functional strengthening, and dynamic stabilization exercises. And again, the doctor will be the one to clear for high impact activity returns, such as sports, impact sports, bike riding. To just take a moment and talk about a really great sport is swimming. These folks can swim throughout, even right after their fixators are removed, as soon as surgically they're clear and their wounds have healed. Okay, so this is the first patient that we did an internal precise on, and this was really back in 2012, I think. And she was a young lady with hypochondroplasia. She did very well. I have somebody sitting in my office right now that has achondroplasia that does have a precise nail, and he'll be available for questions in a few minutes if you want. But so after her lengthening, she was able to return to surfing and just got on with her life very well, and was very happy with her outcome. So, preguntas. Questions?
Frances, había algunas preguntas durante que ibas dando la charla, algunas se repetían y básicamente en general están preguntando, hay una opción entre que si es mejor la fijación externa o la fijación interna para el alargamiento de los húmeros.
Mm-hmm. So, many folks with achondroplasia are not good candidates for the internal nail because their humerus is very, very short, especially children. Those with hypochondroplasia are better candidates for that because they don't have such short humeri. But if it fits within their bone, it's a much easier lengthening than the external lengthening. You can wear regular clothes. You don't have to modify your clothes. And really, you can go through your lengthening and people don't really know you've got much going on. So if you're a candidate for that, if your bone length or your bone width is a candidate for that, that is an easier lengthening. I don't know that you guys have the precise nail available in Spain, do you?
Sí, sí está disponible. Están empezando a utilizarlo ahora porque, bueno, realmente tampoco había muchos doctores muy expertos en lo que era el clavo intramedular. Aquí la fijación es casi toda externa, estaba funcionando bien, pero en el clavo interno, entre que no estuvo autorizado para condoplasia hasta hace poquito y entre que no se ha usado mucho en las operaciones, hay todavía una pequeña duda en las familias, ¿no? sobre cuál de ellos elegir, ¿no? Porque aquí los doctores que realizan la elongación son francamente buenos, pero son expertos sobre todo en fijación externa. Y luego hay pros y contras, ¿no? Porque, bueno, pues y ponen en la balanza el pro y el contra de qué es lo mejor, qué es lo peor, sumado a la experiencia o no del doctor que lo va a llevar a cabo. Pero sí lo hay. Y cada vez se está utilizando un poquito más, cada vez va habiendo más experiencia en ese campo, sí. Sí, lo que no se elonga aquí es el antebrazo, de momento. Se elonga el húmero, pero el antebrazo todavía no se ha empezado a a elongar. No sabíamos, bueno, si es una intervención, que es otra de las preguntas, si es una intervención frecuente en la elongación de brazos en niños con acondroplasia o, bueno, hipocondroplasia, displasia esqueléticas. ¿No? ¿Es común en Estados Unidos la elongación del antebrazo?
Yes, it is. Not so much with achondroplasia because their humeri are so short in comparison. So the nail has to fit within there. Sometimes I know that our team, our doctors are doing some modification on the nail, and I've seen that happen a few times where they modify the nail. But with other diagnoses, other than achondroplasia, we are doing internal humeral lengthenings. So those would be often people that have a unilateral limb length on their upper extremity, or again, we've had quite a few patients with hypochondroplasia. Okay. All right. Any other questions?
Hay otra pregunta que dice que, bueno, que si es normal que después de un alargamiento con fijadores externos en brazos, que no se recupere toda la fuerza que tenían antes del alargamiento. En el caso de la persona que plantea la pregunta, dice que ha reducido mucho la musculatura y que no consigue recuperar la musculatura y la fuerza que tenía antes. ¿Es una de las complicaciones o es habitual que suceda esto?
¿En los brazos o las piernas o los dos? Sorry, in your arms or your legs or both?
En brazos, dice.
Okay. We have not had that issue. It may have to do with waiting long enough and continuing to do your therapy as you're back at home. Because it definitely takes time, probably a year, to fully recuperate your strength, your range of motion. And it takes work. It's something that you have to continue to work on. So, you know, in a few months, you're not going to be back to where you were before you lengthened, but we do see folks recover their strength. We actually have a young man who is into bodybuilding, and what do they call the, he's into these sports where he just won this huge competition, and he had gone through bilateral lower extremity and upper extremity lengthening. So we do have folks that recuperate their strength. I think a lot of it has to do with just continuing to do your exercises, because it's not over from any surgery. You have a knee replacement and it takes you many, many months to recuperate from that, and especially to gain your strength back. You'll gain range of motion before you'll gain the strength back.
Bueno, en el caso de la chica que formula la pregunta, dice que fue hace 25 años. Yo ya eso no sé cuánto será de reversible. La pérdida de fuerza, ¿no? De musculatura.
Yeah, I can't speak to that particular case because I don't know, you know, what happened and was there an issue? I don't know. But our patients do very, very well with the upper extremity lengthening and the recovery afterwards. Again, it's one of the easier ones. Kristen, I believe you had also an upper extremity lengthening. Can she give her take on that? Kristen DeAndre?
Yeah, I had upper extremity lengthening, and I have since that was 20 some odd years ago. And since I've had the upper extremity lengthening, I have worked out with a trainer and have regained, I mean, all of my strength, if not more. It's hard work. I mean, you lose a lot of muscle mass, you know, and you're stretching everything when you're lengthening. So it takes a lot of time and more dedication to regain everything, whether it's upper extremity or lower extremity lengthening.
Hay otra pregunta que dicen que si hay diferencia entre el tiempo de rehabilitación para ganar esa movilidad, esa musculatura y esa fuerza, si hay diferencia entre si hay fijación externa o si hay fijación interna. Si has visto alguna diferencia.
I would just say that you're able to do more things with the internal than you are with the external. And I think there's probably a little less pain with the internal because you don't have the pin sites, you don't have the awkwardness of having an external fixator on you. But the rehabilitation phase is pretty similar. You just have less discomfort with the internal. You still have to do the same stretches. You still have the same amount of time with the internal as the external for the upper extremity. For the lower extremity, I would say it's about the same too. We see some differences in the rehabilitation of those with internal rods for lower extremity lengthening, like different muscle groups tend to get a little bit tighter. I know that's not our topic today, but when you're doing an internal femoral lengthening, you tend to get tighter in the hamstrings. And when you're doing an external femoral lengthening, the quads tend to get tighter because the pins tether the tissue, and it's more painful to flex your knee versus extend your knee. So we do see some differences in internal and external, but in general, you still have to rehabilitate very similarly, and it's a lot of work. It's not an easy process either way, but it's less painful typically with the internal.
Con respecto a las infecciones, también preguntan si has visto que hay más infecciones cuando son fijaciones externas, o que si hay, aunque sea fijación interna, incluso en los húmeros, hay también ha habido casos de infecciones. Y en ese caso, ¿cómo se trataría? ¿Hay que parar la rehabilitación? ¿Hay que intervenir de nuevo?
Okay, so that's a really good question. So I'll talk in general, and then I'll talk specifically about the humerus versus the lower extremities. If the patient has never had an external fixator on that segment, the risk of infection with an internal rod is lower. But if the patient has had external fixator on that segment, then there's a little bit higher risk of having an internal rod. We manage those really well at our center. We know how to prevent and also how to recognize them if they occur. And we're trying now at this point to get folks through their lengthening without ever having to have an external fixator. So that's kind of our goal. If it can be achieved, it doesn't always work because sometimes for whatever reason, they do need to have an external fixator before they are candidates for an internal fixator later on. So if there has been an external fixator with pins going into the bone, even though they didn't have an infection that became aware, you still perhaps have latent bacteria in the bone or something that can be reawakened when you insert a rod. So they get prophylactic antibiotics in the operating room, and then they are on antibiotics for a period of time after the surgery. And then also we're watching and monitoring every day that they're in therapy, and then with their follow-up appointments. So if there is any sign of infection, we're on it very quickly. And then, we have protocols to deal with that. If you've never had an external fixator and you have an internal rod for your very first surgery, the risk is lower. And we know that most folks that have external fixators, sometime in that process are going to have a pin site infection. But if you start off with an internal precise or intermedullary rod, your risk of having some type of infection is much lower.
Hay otra también pregunta relacionada con el tema del nervio braquial, por el que a veces al hacer la intervención de elongación en el húmero, hay veces que ese riesgo existe de tocar ese nervio, a veces se toca, bueno, pues porque, qué decir, esa es una de las complicaciones que puede existir. En el caso de que se toque y que se detecte algún tipo de parálisis que se refleje en la mano, ¿es reversible? ¿Hay una rehabilitación específica para trabajar eso o tendrían que someterse a una nueva intervención porque ese nervio ha sido tocado y tiene que ser intervenido? ¿O con rehabilitación eso se puede solucionar?
So if the nerve is not working well, it could be for a variety of reasons. One can be that it occurred during surgery and there was some type of disruption of the nerve, which is, which again takes healing time. But it also can be as the lengthening progresses and the tissues become so tight that the nerve becomes entrapped. And if that's the issue, they can go in and they can open up the tissue around the nerve so they free up the nerve. They're not disrupting the nerve, they're actually taking some of the pressure off the nerve. We see that sometimes in the upper extremity lengthenings, but it's much less common in an upper extremity lengthening than it is in a lower extremity lengthening. So often the peroneal nerve will become entrapped in a lower extremity lengthening, and they'll go in and they'll do a peroneal nerve decompression. And then that takes the pressure off the nerve. And we watch for those signs and symptoms with each visit. So if they're getting nerve pain, if they're getting burning pain, if they're getting positional pain on a position that would put the nerve on stretch, and the nerve is responding with either the burning pain or especially loss of motor function or paresthesias, that's all indications of nerve either disruption or nerve entrapment. And so those are things that we're watching out for. And you have to know as a the physician has to be aware of those and how to treat those. So and to diagnose how it's occurring. Did it occur in surgery? Did it occur because of positional? Is it occurring because of swelling? Is it occurring because of tight tissues entrapping the nerve? All of those things, you need to go down that list of differential diagnosis and why that's occurring. And then it needs to be treated according to what's why it occurred. Oh, sorry. I also, as I'm thinking down that list, you also want to be aware of, is it coming from the extremity or is it coming from the spine? Let's take a second to talk about the 4-segment lengthening and talk about spinal stenosis. That can also occur. So if we actually have them screened for spinal stenosis before their 4-segment lengthenings, and some of our patients, even young kids, have to undergo a decompression before they're candidates for limb lengthening surgery. And this is something we weren't doing before Dr. Feldman came here. And Dr. Feldman is an excellent spine surgeon. I think he spoke with you guys a few months ago. And so based on his recommendation and his experience, now we are doing that. And so I think our patients are really benefiting from that as well. So when you have a patient that's undergoing a 4-segment lower extremity lengthening, there are certain things you're doing to not overstretch that nerve, even if their spine is healthy. For instance, if they're in a wheelchair with their knees extended, which you want them to have knees extended so their knees don't get tight, you need to recline the back of the wheelchair so that you're not overstretching their sciatic nerve. So there's things to do to prevent and then to treat. Okay.
Perfecto. Y nada, que hay una sugerencia de que ya que tienes este paciente contigo acompañándote en la consulta, si, bueno, pues mira, yo que sé, dejando de compartir la pantalla, que podemos ver la imagen más grande, puedes hacer algunos ejercicios, o él puede hacer algunos ejercicios que que él mismo pueda hacer cuando llega a casa, independientemente de que tenga la rehabilitadora con él, ¿no? Ejercicios particulares que a él le pueden venir bien cuando llega a casa o al hotel o bueno, donde puede, ¿no? Después de la operación, que habitualmente no le perjudique, pero que sí que le ayude de manera sencilla. Si puede hacer algo ya, ¿no? Aprovechando que lo tienes ahí.
Yeah. Okay. Before I turn my screen, I'm going to tell you guys we are moving in a few days. So behind me, it looks very calm and organized. Over here, it doesn't. So just excuse that. This is Andrew Durelia, and I'm going to turn. Now you're going to see a mess.
Mira, perdona, Frances. Perdona, Frances. Puedes dejar de compartir pantalla y yo creo que así vemos la imagen más grande.
Oh, yes. Sorry. I misunderstood. Yes,
y así le vemos mucho más grande. Eso es. Podemos poner incluso vista galería a los que quieran y así le ven mucho mejor.
Okay. There you
o
go.
vista,
So
vista del hablante, yo creo que se puede poner.
There he goes. Okay. There he is. Can you see him? Can you hear him also? Okay, so he had his surgery 1 week ago, right?
Yeah, 1 week ago.
Oh. And this is?
This
kinesiotape for
a scar.
Oh, okay. So they're doing
like this from a previous external lengthening.
Okay. All right. So this is Andrew, and Andrew had an external lengthening elsewhere. How many years ago?
That was 2008.
Okay. And he had some complications with that I'll let him tell you about. It was not at our center.
Right. I had external lengthening done in 2008. The goal was to get 4 inches, and I started doing that, and I ended up stopping at 2.5, I think, due to complications, and it was very difficult, the external, and it just a lot of complications, and that was done with a different doctor. And then I ended up getting RSD, which is not fun.
No, so RSD is reflex sympathetic dystrophy. It's now complex regional pain syndrome. So again, talking about nerve pain, Andrew is an example of what can happen. And again, it wasn't at our center. I do remember you coming here later, and he had nerve decompression at our center, but that was a long road for you.
Yeah, that was over a few years, and then it took a long time to recover. And they also did I have what some achondroplasia people have, where the ulnar nerve is shorter than the other one, so I did a lengthening here, but they didn't do it here because that one's okay. And I had this done too, but
you had carpal tunnel releases. So he's had a lot of nerve decompressions because of his first humeral lengthening with external fixators. And it's not to say that everybody with external fixators will need the nerve decompressions, but he had a complication somewhere else. So
yeah. And then so now I had the precise done last week, and it's easy. This is nothing compared to the external.
Can you see this very small? That's his osteotomy site.
It's a bruise.
Here's where they put it in, the nails.
Yeah.
Very small.
And
do you see that? He's got quite a bit of bruising right now, but that's just post-op. It will go away. And he's still got swelling, but he's moving around extremely well.
Yeah, it feels fine. Yeah, it's amazing.
Questions?
Muchas gracias por el ejemplo, muchas gracias por mostrarnos y contarnos también tu experiencia. Frances, ¿tú crees que hay menos posibilidad de tocar ese nervio si se hace fijación interna con el clavo que si con la fijación externa? ¿O no está estudiado eso? O por lo menos bajo tu experiencia también, no lo sé.
So we don't see it often here. We don't see the nerve issues with, I think it has also something to do with the experience of your surgeon. I think that's a huge one. We don't see it very often here. we've had some positional issues where they were in a position in the OR for a long period of time and they woke up with a little bit of weakness. And but again, we see lengthening all day long. And so we can very quickly catch something where at another center, they may not do it as frequently and they may not catch it as quickly. So it's really hard for me to say, you know, because I know how our center works. And because we have the ability to have many cases under our belt, I don't know how to say that in Spanish, but we have a lot of experience with it. And there's nothing quite compares to seeing many cases, because over time you've seen almost everything. And once you've seen one thing go wrong, then you know how to prevent, you learn from it, and you hopefully prevent it from happening again. Or at least if it's something that's a little more common, you develop different techniques so it doesn't continue to happen again. So not to say we never have complications, certainly we do, but because we've seen so many things, I think that we're not seeing I just rarely see upper extremity complications that aren't caught pretty quickly here.
Pues sí, la verdad es que la experiencia siempre te hace, no es que no cometas errores, ¿no? Pero sí que te da experiencia es corregir esos errores para no volver a cometerlos, porque además vas a tener una oportunidad enseguida, al tener tanto volumen de trabajo y de casos, vas a tener la oportunidad enseguida de poder hacerlo bien y también aprender de las cosas bien hechas. Así que desde luego que la experiencia es un grado. Complicaciones siempre hay, porque es así, porque están ahí, pero sí que detectarlas y a veces prevenirlas sí que es fantástico, pero claro, eso te lo da pues eso, sí que la experiencia que tiene todo tu equipo y todo el instituto, ¿no? Que trabajáis allí. Aquí no hay más preguntas que yo haya visto, déjame chequear lo último. Bueno, dicen, habían preguntado que en el caso de piernas, ¿cómo se puede saber si hay problemas en los nervios? ¿Cómo se puede saber si es un problema de espalda por compresión de nervios en las piernas? Pero yo creo que eso que sí que lo has dicho ya, ¿no? Yo creo que habías hablado un poco de la parte inferior, cómo detectarlo.
If you want, I can share a couple slides with lower extremity lengthening, or I don't know what our time frame is. Do you want those? Yes?
Nosotros sí, lo que no queríamos era robarte más tiempo a ti. Nosotros estamos encantadas de escucharte.
Okay. That's fine. So I just have to figure out a little bit of screen sharing to a different PowerPoint that's up. Let me get okay. So I can go through this really quickly if you want. It's talking about bilateral femoral lengthening and forced segment lengthening for dwarfism, talking about hypochondroplasia, achondroplasia, and pseudoachondroplasia. Another way we also do forced segment lengthening.
No se ve la pantalla, perdona, Frances.
Oh, I'm sorry. Hold on. Sorry, I need to screen share first. There's screen share. And I think it's that one. And now share. Can you see it?
Sí, yes? Perfecto.
Okay. Thank you. I forgot to screen share. Okay, so with bilateral femoral lengthening and possibly forced segment lengthening, we use it to treat a variety of conditions. Dwarfism is the most common. It can be an internal fixator or external fixator or a combination. We use it with achondroplasia. We use the 4-segment lengthening with hypochondroplasia and pseudoachondroplasia. Also, we use it with cosmetic lengthening. We do some cosmetic lengthening, and we will go on. So bilateral femoral lengthening, actually, I'm not going to go. I'm going to just blow through some of these. Okay, so let's go here. So this is a 4-segment lengthening. This woman was done with external fixators. It's talking about how over the series of a lifetime, they can get 14 to 16 inches of height. This particular woman got 14 inches. And I say woman because these are old pictures and she is a woman now. I think she works in Washington, D.C. now. So it talks about how many tasks can be very difficult in society when you are a very short stature, including using public restrooms, accessing things in society such as grocery stores, and even how using a bathroom not only is difficult, but it's also not very sanitary when you have to use your arms to climb up there. We did talk about also the difficulty with personal hygiene when your spine becomes stiff, so I won't go over that again. This is a 4-segment lengthening with an external fixator, and this actually has, the top has a, I can't find my cursor. The top has a modular rail system and the bottom has a Taylor spatial frame. This is a bit of an older picture. Nowadays it would be a Vilex and a drive rail. And this is an X-ray of external fixation. We took a second to talk about the nerves. Our doctors do the rail system, the Vilex or the modular rail on the medial side of the lower leg, sorry, to avoid any complications with the peroneal nerve. So that is why you see those on the inside. We want to stay away from that peroneal nerve on the lateral side. Now this is a hybrid, so we're doing in the one on the left. It is precise nails at the top, and it is the modular rail or the Vilex at the bottom. And on the photo, or the X-ray rather, on the right, it's all being done with precise nails. These may have been stride nails. Stride nails are no longer on the market. This is just how to turn someone that has 4 segments undergoing. This is a young man with pseudoachondroplasia. I don't think he's a young man anymore. I think he's in his 20s. But so turning can be difficult. I really didn't mean to play that X-ray, but, or rather that video, but it just went automatically. So, all right. So durable medical equipment for somebody undergoing bilateral femurs or 4-segment. They need a reclining wheelchair with cushions and extension on the legs and a pillow underneath. So we talked about reclining. Why? Because you want to recline so you don't put too much pressure on the nerve. They'll need a rolling walker extra wide to accommodate the fixators if they have it. And if it's somebody with achondroplasia, remember that the length of the arms is also very short. So they're going to need a walker that fits them. So you don't fit it exactly the same way as you would of somebody of typical height. And then also for somebody with achondroplasia or some of the other dysplasias, you may need push-up blocks or yoga blocks for transfers, because it's very, very difficult when you can't use your legs to use your arms if they don't reach to the seat. This is an example of the wheelchair that reclines. We've got her reclined to 45 degrees. She's got a bolster, or rather a pool noodle under her legs to help maintain that knee extension so that her hamstrings don't get too short. She's got dorsiflexion splints because she's undergoing a 4-segment lengthening with internal rods, by the way. So she's got dorsiflexion splints. So we've got her in a position that she's elongating her muscles even when she's at rest. And this is an example of a custom dorsiflexion splint for somebody undergoing a tibial lengthening. This photo is the splints that our team makes, our great OTs make for the support of the feet. And they use these while sleeping at night and while resting. And they have just Velcro straps to maintain them. This is an example of the push-up blocks that we use, and also kettlebells and the other special considerations. Folks with achondroplasia require special attention to positioning secondary to the hyperlordosis. Ensure that the positioning of the wheelchair and the mat is about 45 degrees to avoid the overstretch of the sciatic nerve. Proper positioning to minimize the risk of lumbar or cervical nerve compression. And then, so sometimes they'll also do a femoral osteotomy performed at the time of the surgery. So this talks about the hyperlordosis and how they can do an extension osteotomy. If you look at the picture on the right, I am so sorry, I cannot find my cursor. I don't see where it is. I would point it out, but if you look at the top of the femur, you can see that they've done an extension osteotomy to help bring that femur into a better alignment. And then they also have the option of doing a release of the tensor fasciae lata. The sartorius and the rectus femoris can also bring that into the pelvis into better alignment and help to reduce the hyperlordosis. So you can see this patient before and after. Sometimes just a lengthening in and of itself, because the hamstrings become a little bit tighter, that can also take care of it. But as you're lengthening, also the anterior muscles can become tight too. And so that sometimes does not help. So these are just some stretches that we do when they have an external fixator, so that we're stretching the tensor fasciae lata so that the iliotibial band doesn't get too tight. Always be cognizant of proper hand placement. Normal stretching pressure can lead to fractures on fragile bones if the hands are not placed properly. We talked about the short lever arms. It is especially true in the lower extremities. The therapist here, again, hands close to the joint. She's using those short lever arms. And here, I think this is actually, this is a video.
Force as proximal to the joint as possible, because 4-segment lengthening in the tibia, the osteotomy site is right here. So I don't really want to be distal to that osteotomy site due to distal fractures. So I'm going to try to get my force right here and ask her to try and help as much as possible. So I'm going to stabilize here. So I want to try and get you to pull as much as you can, and I'll back up that force with my hand right here.
So he's using hands close to the joint, and then he's also having her assist with her muscles, and then he's trying to minimize the amount of force that he has to put there with his hands. So all of these are tips and tricks that we teach our entire team. That gentleman and the therapist in that picture is Mike Thompson. He is a wizard, and he is, he's actually put this particular presentation together. So I thank him for allowing me to steal a few slides for you guys today. And actually, that's all I want to present from his. So that's just a little taste of, I'm going to stop the share. Some of the things. Thanks.
Sí, Frances, no, la verdad es que te agradecemos por lo menos para tener una idea general de haber tocado también la parte inferior de pequeñas dudas. Sí que es verdad que en España se usa todavía más fijación externa que interna, pero nada, a nosotros nos cuesta muy poco emplazarte a una nueva charla cuando buenamente podamos para poder abordar lo que es la parte inferior, la rehabilitación ¿no? de lo que son piernas, miembros inferiores, incluido también con fijaciones externas como los circulares que trabajáis vosotros, porque sí que ahí surgen un montón de dudas, o por lo menos llegan a la fundación, a nuestra fisioterapeuta Carmen Barreal, que tú tuviste la oportunidad también de compartir con ella congreso. Llegan dudas, bien por parte de las familias y bien por parte de los propios fisioterapeutas, que, bueno, que trabajan a veces con niños se han sometido a elongación, pero hay veces que no, que es su primer paciente de un niño con elongación en acondroplasia. Entonces, bueno, nosotros vamos humildemente resolviendo como buenamente podemos bajo nuestra experiencia también en España, pero sí que nos gustaría aprovechar la oportunidad de, independientemente de la charla que des en nuestro congreso, que ya contamos con ella, bueno, encontrar una fecha cuando a lo largo de este año que, bueno, que trabajamos este ciclo de expertos, no tiene que ser inmediata, para abordar el tema de la elongación de miembros inferiores. Sí que sería súper interesante también para España. Bueno, para España y para muchos de los países que nos ven, que no sea Estados Unidos, donde os tienen a vosotros de referentes, ¿no?
Sí, sí. Hay varias cosas males que ha pasado en los últimos años de la pandemia, pero la buena cosa es que ya estamos compartiendo más internacional en Zoom y en YouTube y en cosas así. Entonces, el mundo es más chiquito por algunas maneras, ¿no? No podemos viajar tanto como antes, pero ya podemos compartir el conocimiento, ¿verdad?
Laura, no le oímos o no te oímos.
¿Mejor?
Ah, vale.
Perdón. Tengo un micrófono que había puesto
está por el otro canal.
Sí. Yo creía que era un poco más sensitivo, pero no. Bueno, dije que, bueno, hay muchas cosas que no son muy buenas sobre la pandemia, pero hemos encontrado maneras de compartir conocimiento y enseñar internacional, aunque estemos en nuestros sitios normales, ¿verdad? Pero estoy súper feliz para viajar en octubre, en el año que viene, bueno, en este año, este año a visitar a ustedes y conocer a mi gente de España otra vez.
Pues estaremos encantadas de tenerte aquí y estaremos encantadas de poder escuchar otra de tus magistrales charlas, pues bueno, pues cuando nuestras agendas y sobre todo la tuya, que sabemos que está muy apretada, nos deje, ¿no? Nos dé la oportunidad.
Okay. Muchísimas gracias por la oportunidad.
No, muchísimas gracias a ti por estar siempre aquí al lado de las familias, al lado de todo el mundo y al lado de la Fundación ALPE, que es un valor incalculable para nosotros. De parte de Carmen, muchísimas gracias también. Andrew, thank you very much. Carmen también te quiere dar las gracias y está deseando verte, así que yo creo que sin más, te hemos robado ya un montón de tiempo, lo sabemos, pero es tan interesante que no queremos a veces nunca que terminen, ¿no? Charlas como esta. Muchísimas gracias de verdad y te esperamos de manera presencial en octubre y de manera virtual, pues cuando la agenda nos lo permita.
Okay. Perfecto, muy bien, gracias.
Muchísimas gracias a ti también.
Bye. Chao.
Bye.
Bye.